Well, thank you very much for attending the UCI Mind seminar. Today we have a seminar speaker from the UCI faculty. It's a great pleasure to introduce Dr. Dan Nation for today's speaker. Just a brief biology on him. He received the doctor and PhD in clinical health psychology from University of Miami. Then he went to the UCSD to complete his clinical internship in neuropsychology and also the postdoctoral training under the NIH T32 training grant at the UCSD. After completion of his internship and postdoctoral training, he joined as a faculty position at the USC in the Department of Psychology, where he stays there for 6 years. And after that, in 2019, he was recruited UC Irvine, and he started his associate professor position here at UCI on the Department of Psychological Science. So Dan's research has focused on the role of vascular factors and cognitive aging, dementia, and Alzheimer's disease. Specific projects include MRI studies of cerebral vasculature resistance, biomarker studies of the blood-brain barrier permeability, and blood cell culture studies examining the protective role of circulating angiogenic and progenitor cells. Today, he is going to give us the very interesting talk titled the Improving Diagnostic Classification by Operationalizing Decline on Serial Cognitive Testing. So without any further ado, please welcome Dr. Dan Nation for today's talk. Thank you very much.
All right, thank you for the introduction. And yeah, as Masashi mentioned, my research is predominantly in vascular contributions to cognitive impairment and dementia. But as a neuropsychologist, I also recognize the importance of tracking early stage cognitive decline, and we really need more research on how to better evaluate cognitive measures at the very early stages, preclinical stages of disease. So that's what the focus of this talk is. So we're talking about improving diagnostic classification by operationalizing decline on serial cognitive testing. So that's kind of a mouthful. So let me just try to break it down a little more here. The idea is to try and refine our methods of diagnostic classification to be more sensitive to very early stage declines in people who are at risk for dementia, older adults in particular. And so why is this important? Well, we know that most cases of dementia and of cognitive impairment in older adults are generally insidious in nature. In other words, there's a very long, slow, progressive change in cognition in most people and varying change over time. And so tracking and deciding how to make that diagnosis of impairment or knowing what's normal or abnormal is a key research area. And so it's been recognized for a long time, as you can kind of see on this classic graphical depiction of cognitive decline in dementia, that although there is this early stage, more mild cognitive impairment that precedes dementia, there's also, it's widely believed and just is logical that there would be a pre-MCI decline. So a decline within normal range, what's considered normal range cognition, that is nevertheless sort of a harbinger for future decline or auguring for potential risk to go on to cognitive impairment and go on to dementia. And so this has been the focus, this is really the focus of the talk. And it's been recognized for a very long time. This paper is going back more than 10 years beyond that there's such a thing as pre-MCI declines that can be seen in people at risk for dementia. Also, this has been sometimes referred to as subtle cognitive decline, which is really the same idea that there's an early decline during this preclinical phase. But that term is confusing, I think, because it gets abbreviated as SCD, which a lot of people now use to say subjective cognitive decline. And there's the idea that you could have normal cognition on testing, on neuropsych testing, but have a subjective sense that there's decline, or somebody noticed subjectively that there's something different about your cognition. That's not what I'm studying. So that's a totally separate topic, totally separate talk outside of my area. What I'm interested in is objective declines. And so there's this other term that's been used, this OBJ-SCD, so objective subtle cognitive decline, to make that distinction clear. And so people, there's a lot of confusion, I think, in the literature at this point. So we're interested in objective test measurement. And so there's a pretty exciting recent paper from my colleagues at UCSD where they define this objective subtle cognitive decline based on subtle deficits on neuropsychological tests. And so people didn't meet criteria for MCI, but they had these subtle neuropsychological deficits. And so they classified them as having this objective subtle cognitive decline. And it turns out that those folks tended to accumulate more amyloid in their brains. And so people found that to be quite interesting, that you could have a cognitive marker that may actually predict a very early preclinical biomarker of disease. And it could be of value as a supplemental way of sort of assessing risk during this very early preclinical phase. And so in this way, we're sort of pushing the diagnostic classification back further, earlier than MCI, to identify very subtle risk. And then those folks perhaps are at risk for eventually developing diagnostic levels of impairment with MCI and eventually dementia. So what I'm talking about today is a little different than that approach. I'm talking about a decline on serial cognitive testing. So more than one exam. How do we interpret the change across those exams? That particular study, and a lot of the studies and great work that has been done in this area, is actually focusing on a single exam, just like we diagnose MCI based on a single exam, except that they're looking at people who don't meet criteria for MCI and looking for sort of subtle deficits. But in addition to that, and really completely perpendicular to that, we could actually add and refine diagnostic information, not only in people who are preclinical, but in people with MCI, if we could interpret their change on test scores over time. So that's what I'm focused on, serial cognitive testing. And this is important because it's actually part of the recent research recommendations for the diagnosis of Alzheimer's disease, where they discuss specifically that even in people who are cognitively unimpaired, there may be subtle cognitive declines, and they specifically say on serial cognitive testing. And so that's a key distinction, not just in one exam, but across multiple exams, and that those folks perhaps would be at risk. And then sort of completely separate from that, you have, again, a lot of beautiful studies like the one I just showed that are identifying on a single exam that people can have subtle change. So there's actually a lot of research in this early area coming at it from different angles. Interestingly, when you look at the criteria, it states that MCI, there's an assumption that you have a decline from a previously higher state of cognitive function. So you can't just have impaired cognitive ability and there's no decline and call that MCI. Maybe you were always that way, being the idea. So there has to be some decline. And they specifically mention change on longitudinal cognitive testing as one of the ways to establish that particular criterion that's part of the MCI diagnosis. But of course, in reality, this is mostly done through subjective report. People say, I feel like I'm worse. Or an informant will say, well, we noticed a change over time. And that's how they get at the change in cognition over time, not from objective change on serial testing. We'll talk about why that's the case in a bit. So it's a key distinction here that your level of impairment at a given visit, time point, is what we're talking about here with objective subtle cognitive decline previously defined, MCI and dementia. And I think one way to conceptualize this is that represents your proximity to dementia. So if you have objective subtle cognitive decline, yes, you have some deficits, but you're a long ways from having dementia. You'd have to fall quite a ways in your cognitive performance and ability levels in order to hit dementia. If you have MCI, you're a lot closer. And so you're certainly in a heightened risk state, but you still have a ways to go. And so your level of impairment is critical. I think it's the most important thing because it tells you how close someone is to reaching that dementia threshold. But what I'm interested in here is adding to that information with knowing the trajectory of someone based on their serial cognitive testing. What is their angle of descent? And I think that this is important because it's all over the place. And there's a lot of heterogeneity, and arguably one of the biggest problems with the trials to date has been cognitive heterogeneity, which is mentioned a number of times in recent reviews of trial results, and difficulty sort of managing that with trying to track outcomes. So we need to learn more about how we can characterize someone's, not just their current cognitive function, but their directionality. How are they declining over time? So I'm just going to give a couple of clinical examples to help further contextualize this and show some of the problems and what is currently done, not only in research, but in clinical practice. So very simple examples. Patient one presents with some memory concerns as an older adult. They're given a delayed recall memory task, a sensitive task that would probably pick up on memory problems. And let's say they score a 13 out of 30. Well, is that normal? Do they have normal memory? You sort of ask yourself, is this normal? Well, there's no way to know. How would you possibly know whether that's normal or not? You have to know what is normal. How do normal people perform? So how could we possibly know what that is? Well, this is a very standard thing. We collect a normative reference sample, a group of people, older adults, who we know didn't get dementia. Maybe we followed them for many years. They never developed cognitive impairment. They never developed dementia. So we can go and look at those data and determine what normal performance is. And this is how we do this. So this is how we use cognitive testing to diagnose MCI. And so you can generate norm reference Z-scores in this way that can be demographically corrected and so forth to get a sense of where someone actually falls on a standardized score. So let's say there is a Z-score of negative 1.5. Okay, so for a lot of folks, that would be the threshold or beyond the threshold for making a diagnosis together with other diagnostic criteria. And so it looks like maybe this person might have MCI diagnosis if they fit the other criteria. Okay, so, but what I'm interested in is the next thing that happens, which is an extremely common situation. The person comes back the next year and now they score 16 out of 30. And let's say that is a Z-score of -1. Okay, so in that case, they seem to have improved. And if we're using 1.5 as our MCI diagnostic threshold, they would potentially not meet criteria for MCI anymore. So what does this mean? Does the patient have MCI or do they not have MCI at this point? And it's really a problem that has many considerations that have to be taken into account. So for example, is this a sub-threshold case? We have to arbitrarily draw the line at 1.5 standard deviations, just like we draw the line for whether or not to treat blood pressure. It's the same problem in many different areas of science. So it could just be this is a patient that still has MCI. They're just kind of sub-threshold at this point. Okay, could it be that there was a diagnostic error in the initial exam? They didn't really have MCI. There's something wrong. Somebody made a judgment mistake, or there was some other kind of error and they don't really have MCI. Another possibility people often point to is test error, that neuropsychological tests maybe have error problems or are not reliable enough. And so this could just be an example of testing error, but in this case, we wouldn't know whether they have MCI or not. But another consideration is, what about practice effects? This person improved, but don't we expect people to improve? And in fact, people do improve, and practice effects are common, widespread, and they can be prodigious. So if somebody gets tested and they're naive to testing, the next time they get tested, they will do better. And this happens, it does happen not only in people who are normal, but also in people who have cognitive impairment. There's a lot of heterogeneity in how people perform over time. And so in this case, the person no longer meets criteria for MCI, but it's just not clear what that means. Do they still have MCI? Is this a practice effect? Is there a diagnostic error, test error? All these different considerations. Another one that doesn't often get brought up specifically is maybe the tests are accurate, everything was done correctly, but in fact, the person's brain is fluctuating in its function. That's, after all, what these tests are designed to do, to measure brain function. And so the brain isn't in the same functional state all the time. It fluctuates throughout the day, across days, probably seasonally. If you have a pathological process, your brain may have fluctuation even as it is declining. And so a lot of times we assume there's testing error when we see fluctuations in scores, but they may actually represent real changes in brain function day to day. And this is illustrated by the fact that people who get MCI, even if they revert back to normal, they continue to be at risk ultimately for developing dementia. And that's been shown in a number of longitudinal studies. And so I think that's also an important consideration here. But the reality in the clinical practice world is that none of this is really done in a sophisticated way. From my perspective, we rely on clinical judgment. We have to just make a determination. Whereas to make the diagnosis of MCI, people frequently will use diagnostic criteria when they're interpreting change over time. The reliance is heavily on clinical judgment and subjective reports. And I think it would be better if we could contribute to that with a little bit more objective scientific approaches to this problem. And that's sort of the nature of the problem that I'm trying to address. Okay, so let me give you a second patient example for some more problems. So same idea, memory concerns. Let's say this memory task is a 16 out of 30. Z-score is a -1. Okay, so that's not meeting criteria for MCI. So it's a subthreshold case in this instance. But we discover from that there's prior year of testing. And if you look at the prior year of testing, you see that there was a 19 out of 30, which let's say is a Z-score of 0. Okay, so in that case, we see that this person declined 1 standard deviation from prior testing. So the question is, this person is subthreshold, but they're also declining. Is this pre-MCI? And this is a way a lot of people will think about this problem, is that you have lots of subthreshold cases, but if they're declining, then maybe that suggests that this really is impairment above and beyond whether they meet that exact cutoff. So again, there's lots of considerations here. Is this decline reliable? That's a key question, again, relating to test error and fluctuation of brain function, all these other considerations. And so there's a whole literature on just trying to use statistics and some test parameters to try and guesstimate what would represent a reliable decline. And people will pick arbitrary thresholds similar to what we do with MCI diagnosis. If you decline 1.5 standard deviations or 2 standard deviations, then we'll consider that reliable. Maybe 1 standard deviation isn't a reliable decline and it's just test error. But there's a number of problems with this. In particular, don't we expect practice effects? Is a decline from going from 0 to -1 actually a 1 standard deviation decline, or is it actually a greater decline if in a normal person we expect a prodigious practice effect? And they're not showing it. Not only are they not showing it, they're actually showing a little decline. So that actually obscures this and shows that you can't just use these simple cutoffs in order to make that determination. And really the elephant in the room here is, what is normal change over time in this particular population? And so I think that we can address that the same way we address diagnostic testing for an MCI diagnosis. How would we possibly know what's normal? Well, we take a normative sample and we standardize our scores based on that, and that we already do that. So I'm just proposing we do the same thing for serial testing that we do for single exam testing. That's the sort of gist of it. But in reality, once again, for reasons that are kind of obscure, even though all this data is available clinically, people will apply all these cutoffs and criteria for a single exam. But once it's serial data, people just kind of look at the scores and think about it and then make a determination without actually applying any sort of criterion for normality or abnormality. Okay, so there are many different ways to do this from like a statistical standpoint. And I'm not necessarily arguing for one or the other. I've actually tried a number of different approaches and you basically get the same answer. The ultra simple way to do this would just be to get a change score. So in that case, it's like 1 standard deviation. Get a change score from a normative sample. Again, identifying a robustly normative sample and find out what's normal change over that period of time. You take the average and you divide by the standard deviation and you get a z-score. And we've done that, and you get basically the same result. But a slightly more refined way to do this from a stats perspective, and the way that I've chosen to go about this, is to use regression-based norms, which is a little better if you're ultimately going to take into account other factors like demographic factors and so forth. And it's a little better in terms of samples. You don't need as big of a sample to get a good normative database using regression. So the idea is to find this normative sample that has longitudinal data, so we know that they're not going to get dementia. So we think what they're doing in terms of their change in these tests over time is normal. And you can build a regression model by seeing how the baseline test score predicts their score a year later. And so you get a simple regression model with an intercept and a slope, and you can then have a sense of how baseline scores predict a year later scores. And so if you know someone's baseline, you'll be able to predict how they ought to perform a year later based on a normative sample. And this is the same exact methodology we already use for developing norms for single exam tests. It's just being applied in this case to a longitudinal serial cognitive testing. Okay, so once you have done that, then you would take a test sample, or in this case, an individual patient score, and try to figure out whether this is normal. So you have their baseline score when they first came into the clinic, and you plug it into your normative regression equation model, and that computes a predicted score. This is how they should perform at follow-up based on where they are at baseline. And then once you've actually followed them for 1 year, and now you know their actual performance, then you can just examine the difference. So there's a discrepancy between how they ought to have performed based on norms and how they actually performed. So you subtract those to get this discrepancy, and you can standardize that into a z-score by using the standard error of the estimate from the linear regression equation model. So ultimately, you just get a z-score that tells you how normal or abnormal somebody's performance was 1 year later relative to a robustly normal sample. And so once you have norms, then this allows you to use that information and to apply thresholds just like we would in a single exam to try and understand how we can further refine our diagnostic classifications. Maybe somebody's still within normal range, so they're subthreshold, but they've declined. Now we'll know how much they declined. Was this really abnormal? And so I applied this to the ADNI sample. It's a convenient sample because it's very large and very well characterized with biomarkers and with longitudinal follow-up. And they have a lot of neuropsych data, not the best battery, but a solid number of tests that we could do this on. So I just applied this regression-based model, and I want to clarify that I did not invent this idea. You know, the idea of using regression in this way has existed for a while. The key difference that I have added here was to develop norms, because I think that's really the key. You have to know what's normal. If you don't do that, it's not very valuable because you're including impaired people, and it just ends up being not particularly predictive, in my opinion. So we identified robustly normal people. These are people in ADNI who stayed in ADNI for a while, number of years, never developed cognitive impairment, never developed dementia. And there were 294 of them. And so it's a pretty solid group of folks. And again, we just applied these same methods to develop a linear regression equation from them to find out what's normal change over time. Okay, so then we took the rest of ADNI as the test sample. And we were able to compute in 1,074 people who didn't have dementia. We were able to compute what their neuropsych decline was over a 1-year period. So one thing I want to address, because sometimes this comes up, is that people think maybe this is circular. If we're going to take cognitive tests to identify people who are declining on cognitive tests, and we use that to predict dementia, which is defined by cognitive test performance, isn't that circular? And so I think to address this, there's two things. Number one, they're not the same tests. So the tests used in ADNI to diagnose MCI and to diagnose dementia are completely different than the tests that I used to develop the neuropsych decline score. And so it actually was somewhat helpful that they didn't really use the neuropsych tests in the diagnostic classification. They're just kind of there in ADNI. So in this way, they were independent methodologies. But number two, I don't think it's circular, because if you have someone who's normal and then a year later they're still normal, and you can quantify this subtle decline metric and predict whether or not one day they have dementia, it's just a very clinically useful thing. And it's really consistent with the new approach to Alzheimer's disease that was laid out by Cliff Jack, which is that the disease is measured by biomarkers and cognitive dysfunction is measured by cognitive markers. And so it's not circular to use amyloid to predict amyloid from the CSF to predict amyloid at autopsy. Is that circular? No, it's a biomarker of disease. In the same way, I would argue neuropsych tests are cognitive markers of a cognitive dysfunction, cognitive disorder. And so they may be useful prognostically. Okay, so another thing that I want to address is that often comes up is people say, well, what domain are you studying? What is this, memory? Is this executive function? Is this language function? There's a variety of forms of cognition. And so in these initial studies, I have focused on a global scale. So we do have memory, executive, and language tests that we know are sensitive to early stage Alzheimer's disease dementia. And so I've just averaged the decline metrics for all of them to obtain one single score. And the reason I've done that is that numerous studies have shown that in the early stages, you actually have quite a bit of, again, heterogeneity. Different domains may show impairment in different individuals. And there's, again, a rich literature on this showing that there's really different subtypes of MCI. They may have variable risk, but they're present. It's a lot of heterogeneity. And we did a meta-analysis showing that in preclinical AD, there's even more heterogeneity, and that actually global cognition is the best index in our meta-analysis of something that's related to preclinical AD biomarkers in normal people. So for that reason, I averaged them all, though I absolutely think that'd be interesting to look at different domains at some point. Okay, so I use this neuropsych decline metric to try and see if we can predict future dementia independent of all the other key risk factors. And so this is a Cox regression model where we had demographics, age, sex, education, ApoE4 genotype, major genetic risk for AD, all the CSF biomarkers of the ATN scheme, amyloid tau, and phospho-tau, and total tau, and baseline cognitive diagnosis. So whether they were normal or they had MCI already, we included that in the model. And what you see is there's an incremental, statistically highly significant predictive value to the NP decline metric, and it's linked to a little more than twofold increased risk. And you'll notice, though, that the hazard ratio is still highly significant and actually larger for cognitive diagnosis. I think how close you are to dementia is the most important information. Are you normal or are you MCI? But then the next piece of information is, are you declining or not, as we'll see. So these are the curves from the Cox regression model. And you can see here that the dotted line, the dotted blue line, is people who are normal and they did not show neuropsychological decline. Okay, so those folks are not really at risk for dementia, very little risk. And this is stratified by AD biomarker levels. So whether they're biomarker negative or amyloid positive alone, or p-tau positive alone, or both amyloid and p-tau positive, in each instance, the dotted blue line is at low risk. I think this is important because we're talking about people who are cognitively normal, but they have Alzheimer's disease. They have amyloid and tau in their brains in this lower right figure panel, and yet they're not really at that big of risk. And there's actually a huge range of risk. And so I think the cognitive diagnosis and diagnostics is very important in determining risk beyond the biomarkers. And so that should be taken into consideration for treatment decisions, particularly when the treatments have scary side effects, are invasive, are extremely costly, and people may have other things going on that need to be treated. So it's, I think, important information. The dotted red line is people with MCI, but they were not declining at their 1-year follow-up. So they have MCI, but they're not really showing decline. And you can see they're at greater risk than the dotted blue line, but they're really not, they're far from the red line, the solid red line. So they're not as nearly as big of risk as people who have MCI and are declining. And so that to me is important information, because that MCI toggles back and forth, and between having a diagnosis, don't having a diagnosis, and that part of that may be captured by just taking into account decline trajectories. You can maybe see how someone's doing. In the red line, the pernicious, there may be a more pernicious form of MCI where they're really at high risk. And I think that's important clinical information, because when people come in, you tell them they have MCI and you don't really know what it means, and they may revert back and so on and so forth. So if you were at least able to determine trajectories, that may be prognostically important. And then you have the solid blue line, which in many ways is the most interesting line. This is people who are normal at baseline, they're normal a year later, but they showed an abnormal degree of decline over that period of time. And so this is the preclinical subtle cognitive decline group. And you can see they're really at much greater risk than the dotted line, dotted blue line. And they're at similar risk to people who have been diagnosed MCI, but are not declining. And so this stratification, I think, is really more than just reifying, the degree of cognitive impairment, which is really, linear. I think these categorizations actually can help inform us diagnostically. Okay, so then that was just the initial study, and then I wanted to apply this to another sample. So we have this ADNI robust norm group. Can we apply this to a new sample and replicate our findings? And so I took the NAC database, which is much larger and much more heterogeneous, as anybody knows who's used NAC. I mean, this is just where people are pooling data from all over, all different kinds of patients, different populations of older adults. And so there were 6,794 of these people that didn't have dementia at their baseline exam. And so I did the same thing. I took that data and I calculated their predicted scores based on the ADNI robustly normal sample, and then examined this Z-score representing the standardized change over 12 months in NAC, and tried to use that to see if we could predict longitudinal follow-up, whether other people end up with dementia. And because it's NAC, you have a lot of follow-up. So we had 18 to 158 months follow-up. So there's a range of follow-up, but we also do fixed follow-up at 4 years, but we also look at the full range of follow-up, which is very long in the case of NAC, which I think was nice to have. And again, I use the same approach where we're just averaging the scores from different domains to get, one overall NP decline score at the end of the day. So this is the NAC sample. It's got this idiosyncratic way of diagnosing where you have normal cognition, and then you have, that's where most people are, 4,600, more than 4,600 people. But then you have MCI, impairment without MCI. And then you have impaired with MCI. So I'm calling that MCI minus, MCI plus. So the MCI minus is kind of like a sub-threshold group, and it's smaller, but it's a potentially interesting subsample. So we included that. And this is the stratification. So the vast majority of the people are normal, and most of them were not declining, sort of what we expect. But we had a fair number, well over 100 to many hundreds in each of the different categories, the same as we did with ADNI. And so when we did this Cox regression analysis, once again, we found beautifully the same stratification. So the dotted blue line being normal people who weren't declining over 1 year, they're not at particularly high risk. Whereas the solid blue, normal people who were declining, they're at much greater risk. And then that same stratification continues with impaired no MCI, that's the green lines, and impaired with MCI, the red lines. In this case, there's no overlap. We have much larger sample for our estimates. So really, we were able to replicate the same basic finding. And actually, we did receiver operating characteristic curves to try and find the optimal cutoff on the neuropsych decline metric for the prediction of dementia in ADNI. And once we had that value, we then examined the same thing in NAC, and we actually got the same result. It ended up being a Z-score that actually is much less stringent than other thresholds. It's closer to half a standard deviation below the mean, which is interesting. It's something I still haven't quite wrapped my head around, but it was the same exact number, which I thought was promising, that perhaps we're really measuring something that's an expected rate of normal decline versus a deviant rate of normal decline that may have clinical value eventually. Okay, so as a next step, I mentioned that I think the biomarkers of disease should be, one thing, and then you have cognitive markers of cognitive disorders is another thing, but people are still interested in the relationship between the two, whether amyloid or tau or neurodegeneration are related to cognitive dysfunction. And so I wanted to study in normal people, okay, so very early stage, cognitively unimpaired individuals, is this neuropsych decline score related to the Alzheimer's disease biomarkers. And so we could do this in ADNI because we had all this great biomarker information, and really I've just barely begun this work. And as a cursory analysis, I took people who are cognitively normal and they had amyloid and tau positivity. If they had that, they're at risk for Alzheimer's disease, or they have Alzheimer's disease. They sure enough had greater neuropsych decline. And here on the y-axis, I've flipped the scale, so don't get thrown off by that. Higher values means more decline in the people who had amyloid and p-tau positive. And it's not a massive effect, but keep in mind, these people are cognitively normal. So this is within normal range cognition. We already can see statistically significant effects related to the biomarkers of disease. We found a much larger effect when we looked at neurodegeneration. And so I think it could be that the cognitive dysfunction is really tacking with neurodegeneration regardless of the cause, because it may be that beyond amyloid and tau biomarkers, there could be other things influencing neurodegeneration in this population. And so we actually did a voxel level comparison of brain volumes between normal people with neuropsych decline and normal people without neuropsych decline. And this is what we found was a very highly significant bilateral medial temporal cluster within the hippocampus and related areas that was statistically different between people declining and not declining. So decliners had smaller volumes there. Excuse me. And this was significant after family-wise error correction, which is a very stringent correction. So this was surprising to see it's such a specific medial temporal finding, and to see that it was so large in terms of the relationship with neurodegeneration. So for future studies, I'm really, obviously, as I mentioned at the beginning, my main research area is vascular contributions to cognitive impairment, but I'm interested in the idea of preclinical vascular markers. And this is discussed a lot in terms of Alzheimer's disease. You have preclinical Alzheimer's disease markers. Someone's normal, but they have amyloid and tau in their brains already, and so they actually already have the Alzheimer's disease, and this is putting them at a long-term risk for dementia. I think we can apply the same concept to vascular markers. Lots of people have imaging markers of cerebral vascular disease, or at least what we think might be cerebral vascular disease, in white matter lesions, cerebral microbleeds, perivascular space expansion from these small vessels that penetrate deep into the subcortical regions, and others, lacunar infarction, subclinical infarction, all these different markers of vascular disease. Often they show up in people who are cognitively normal. So isn't that a preclinical marker of vascular disease? I think it is. I think it puts them at long-term risk. And so the main emphasis I want to place is in future studies is trying to understand whether we can track that, and that may be partly what is being picked up by neuropsych decline. So, and actually we try to do this in ADNI, but the white matter lesion data in ADNI is kind of a mess because there's two different methods, and it's not particularly detailed. And so we're actually reprocessing all of that using our own methods to try and get a better sense of the cerebral vascular markers in ADNI and what may be going on there. Even though that wasn't the focus of ADNI, we've actually found a lot of interesting vascular factors in ADNI. And so we'll see. Amyloid and tau contributed to neuropsych decline, but it was fairly small contribution. And increasing research is showing that in addition to amyloid and tau, you also need to have some vascular factors in order to really get the decline, the serious decline that we see into cognitive impairment and dementia, even in patients with Alzheimer's disease, with the classic amyloid and tau markers. And so that will be the focus of most of my future studies. But another thing that I've been criticized for in this, so I want to address it, that we're working on, is that I didn't include any other demographic factors in these norms. I'm just looking at what's normal in this robustly normal sample. And so clearly, we want to take into account how old someone is, what their education level is, their sex, perhaps premorbid IQ to get at cognitive reserve factors, or other SES factors. People have often raised that, although it's unclear how to include SES and other potentially racial and ethnic factors to try to address some of those issues of health disparities and so forth. So we're working on this. We're building bigger models. And one of the key elements here is to have flexibility in the time interval. I just chose 1 year because that's often the way patients are followed in the clinic. It's often the way participants are followed in longitudinal studies of aging. And so it could be useful to have the 1 year norms, but it could also be useful if we just had it based on month, and this is just a flexible random variable, and we can put in whatever the delay interval was, and we can calculate their decline based on that. And so we can actually do this with NAC. It's sort of been done. It's just that they didn't, again, use norm referencing, which is the key to this whole research project. And so this is ongoing work that we hope to have completed relatively soon. Okay, so some of the strengths of the approach, I think, are that it's flexible across different batteries. People have all their different batteries, neuropsychological batteries, but you can do this with any battery. There's really no assumptions regarding which domains will be impaired. As I mentioned, there's a lot of heterogeneity there. And it's convenient with the annual follow-up, although I think more flexible, any follow-up approach would be better. And these norm reference scores we're already kind of used to working with them. We already use them for MCI and actually dementia diagnosis. So this is just adding kind of another layer to our diagnostic approach. And it complements what we already do. The standard clinical approach, standard biomarker approach, this isn't designed to replace anything. It's just new information we could add on top. As I mentioned, I'm interested in future directions in terms of vascular factors, incorporating demographics, modeling time, but also how does this relate to other folks' efforts to identify, subtle early stage objective impairment on a single exam? Could we apply this serial cognitive testing to improve those approaches as well, and to gain better predictive value for those recent endeavors? So this is just to acknowledge funding sources, also the participants and investigators that collected all of this amazing data so that we could analyze it and try to move the field forward.